It's my great pleasure to introduce our next speaker, Dr. Johannigman. He's a very good friend of mine I've known for about 60 years now. And he's going to come and talk to you about an area of interest that he's had for a long period of time. Dr. Johannigman is a professor of surgery, chief and director of trauma at the University of Cincinnati. And he has been in the military now for how long, Jay? 34 years. That's about a few years older than I am, actually. Yeah. He's still actually in the reserves, thinking about maybe even going back into active duty full-time. He's been deployed more than just about anybody I know. And we're really lucky and fortunate to have him here to talk about some of the major advances in critical care and transport. So without much further ado, I'd like to have my good friend Jay Johannigman give his next talk.
Thanks, Pete. Thanks, everybody. It does mean a lot. Pete's a brother in arms, and we share some common interest, and it's great to be out here. I come from Middle Earth. I'm the thing you guys fly over when you're going out to New York. You look down on us in Ohio, and it's great to be out here, and I want to share with you some of the stuff that Pete and I and some of the others in the room, I understand there are some other people here that we've had the privilege of working on, and I'm going to change some of the traditions and some of the talk. So this is our new line of evacuation, and those of you involved in pre-hospital care, if you're a pre-hospital care provider, one of the things that we've come to the realization of is that pre-hospital care is going to be the most important focus in the military over the next years, because as we look at what happens, we recognized that over 87% of the casualties who do succumb from their injuries do so before they ever reach the first surgical care capability. Of those, maybe a quarter are potentially salvageable. So there's been a great shift in the military of looking. We know that when a casualty gets to one of our level 3s or beyond, the chances of survival are in excess of 98%. Where we lose our casualties is in the pre-hospital care environment and in the transport to definitive surgical care. So that's where our focus is going to be. And we do now call it en route care. There's a lot of terms in the military lexicon: medevac, casevac, tacovac, stracovac. We're getting rid of all those and recognizing that whether from the point of injury all the way till we bring them back to the VA here in the continental United States, it is a transition of en route care. And one of the biggest differences is if you go back to the first examples of aeromedical evacuation in either the Second World War or really Korea, the idea was to simply get the casualty alive from one point to the other. Now our mission is to actually improve the care continuously while we're moving the patients. So I'm going to return to this by the end of the lecture. This is what it's like in the back of a UH-60. It's a pretty intensive environment, just like it can be in the back of an ambulance here in Phoenix. There's a lot of things the medic has to do, the care provider has to do. They have to be able to do all these and stay situationally aware. One of the things that we're very interested in the Air Force, and we'll show our CCAT teams, we like technology, we trust technology, we think there's ways that you can leverage technology and use technology to assign it certain tasks and relieve you, the care provider, of those tasks, so you can narrow down your focus into a more discrete set of operatives so that you can do those better while trusting the machine, and we'll show you some of the things that we've looked at in that respect. For those of you who are not familiar, we, the Air Force, are responsible for the movement of all injured casualties once they've been cleared from the battlefield and have reached the first surgical station. The thing that's different about this conflict during the Operation Iraqi and Enduring Freedoms is that this was the first real test of what we call CCAT Teams. CCAT teams, we realized from the Battle of Mogadishu, were critically important in order to allow our sister services to keep their surgical resources and care resources in theater and entrust to us the care of their injured. A CCAT team is a physician who is an intensivist capable physician, an intensive care nurse, and a respiratory therapist. One CCAT team is responsible for moving up to 6 critically ill patients, 3 of whom can be intubated. You can see the intensity of this mission here. You can see this soldier right here is actually about an hour and a half out of surgery. He has an ICP monitor in him. That's why he's up at 45 degrees. He is intubated, he is sedated, and he's being moved on a 9.5-hour mission to Germany. Please clear. This is what we're going to talk about in the next few slides. We had the opportunity to take a look at our first decade of care over OIF and OEF And in doing so, we had some 3,000 critically injured patients that we were able to move. And you can see from the demographics that these are reasonably sick young men, primarily men, and some women as well, some contractors, but about 3,000 patients with an average ISS of 23. You can see there is a difference for the mortality. The overall mortality of this cadre of 3,000 patients is less than 2%, less than 0.2% in air, and overall about less than 2% once we got our hands on them. The other thing I'll draw your attention to is that the median length of time for this cadre from the time they were injured until they were in Germany is 38 hours. That includes 1 to 2 operations, sometimes 3 operations in theater, the 8 to 10 hour trip from Afghanistan to Iraq, and they're in Germany in 38 hours. So we've been able to flatten this whole timeline that in Vietnam was 3 weeks, in World War II was 3 months, and sometimes 6 months, and we've brought it now down to less than 2 days. This is what it looks like. We always fly at night for tactical purposes so that we're not targeted. That's an ambus, and that's a crew loading a CCAT team and a patient on board. Again, here's what that mission actually looks like. You can see it can be a rather unique environment to fly in, and this is while we're loading. The lights will be turned off in the near future as we go to take off. But you can see that young soldier is asleep. Endotracheally intubated. He has had undergone damage control laparotomy. His abdomen is simply closed in an IABAN. It's not been sutured closed. And we know that we do that because we know as soon as he lands at Germany at Larmsey that he'll be taken directly back to the operating room. There's Bob Medell, a good friend and anesthesiologist who's our CCAT doc. And now Chief Master Sergeant Jones, who I had the privilege of flying with, just a really great respiratory therapist, but setting the patient up for that long flight home. I will tell you that I kind of like equipment, but am somewhat frustrated sometimes by the military. And those of you in the military know, the military doesn't acquire equipment readily or quickly. So we're flying that mission still today. In 2015, we're doing tomorrow's medicine with yesterday's equipment. The monitor we carry still dates back from about 1988, and I'll show you some of our attempts to improve our equipment sets. The other problem is, in order to take care of 6 critically ill patients, our CONOP says you may have to take care of them for up to 24 hours. So we have to carry a lot of gear. We carry somewhere between 320 to 400 pounds worth of equipment. It gets pretty tiresome to not only take care of those 6 patients, but haul all that gear around. That's our equipment set right there. We're constantly looking for lighter, leaner, and more capable, and that will lead us to the end of this presentation of what I think is a big advantage for us. Now, most of us who are care providers here, nurses and physicians, we're pretty comfortable in that ICU environment. We're used to things. We take innately that when you walk up to the patient, you listen and look for certain things. And remember that in our environment, a lot of those cues are gone. All right, we fly at night, we fly in the dark, so you don't see things. We use cargo aircraft as our air ambulances, and the engines on the cargo aircraft are not soundproofed, so we fly in an environment that's about 85 to 95 decibels on the interior. So we all have to wear hearing protection. You will not hear a breath sound. You will not hear a single audible alarm on any of your equipment. Okay, so we have to teach our providers to set themselves up for success, to look after the patients, but you can't use the ordinary cues. Vibration, there's a lot of. We always do a tactical takeoff because the aircraft's going to try to get up above 10,000 feet as aggressively and as quickly as it can. So we'll have about a 45-degree angle of attack as we're taking off. You have to make sure your patient's secure, your gear's secured, and that you're in a position to be able to continue to watch the patient while you're going through that. Think about hypobarism. We obviously fly from Iraq or Afghanistan, Germany, about 32,000, 38,000 feet. The cabin altitude's about 8,000 feet, though. So you have to worry about hypoxia, hypobaria. You have to worry what happens to an endotracheal tube cuff when you go from 0 to 8,000 feet. It expands. So we have to think about hypobarism, and it's fatiguing on the crew as well. And these missions are long. On a good day, a perfect mission, from the time you start prepping your patient until you drop them off at Larmsey, if everything goes right, it's 9 hours. It is not at all unusual to have a hiccup, to have a refueling stop, to have an equipment issue, and these missions can often extend 12, 14 hours. So when you push off and you leave, you got to be ready to take care of that patient for the duration until you get them to Germany. Well, I told you we like equipment and we trust equipment, so this is one of our first attempts to see if we could hand things over to equipment. So this is actually a picture that I took when I was flying CCAT, and you can see a young man there sitting in an ambulance bus, and he looks like he's kind of by himself, and you look real carefully at the back of the bus, there's somebody looking to head out the back of the bus because a mortar just landed outside our compound, and they were heading for the secured areas. But that young man's life is being bet upon that equipment. So is it possible to have equipment that's more robust and more capable of managing patients in periods of time when our attention is diverted. So the first of these things we did is we took a look at our transport ventilator, and here you can see this is our old military transport ventilator called the 754. We worked with funding from the Navy and with NASA, writing software to look at the saturation of the patient. If oxygen saturation was acceptable, then the computer was allowed to turn down oxygen concentration. That both saved oxygen, which is a scarce resource in theater, but also had somebody watching oxygen saturation constantly for us so that if we were diverted or distracted, somebody else was looking after us. This was one of 95 patients that we put through this algorithm at our home institution, University of Cincinnati. We used 95 civilian trauma patients, and I draw your attention to that yellow bar. This is the only patient of 95 that what you're seeing there is the controller. At the far left, the controller gets the patient at 40%, starts to wean them down into the 20% range, and this is the usual kind of protocol that you'd see would be working on weaning. You can ignore that. That's the respiratory therapist pre-oxygenating the patient for suctioning, but what got really interesting was there. And what happened is, and I'll cut to the chase, is the patient actually threw a pulmonary embolus. We later CAT scanned the patient. He had a big right mainstem pulmonary embolus. But watch what the controller did. The controller simply every 3 to 5 seconds was checking sats and just stepped itself back upwards. And if you look at the saturations never drop. The lowest that patient's saturation got was 91%. Now, you and I know in our ICU, if somebody throws a PE, the alarm's going to go off. We're going to suction the patient. We're going to readjust the sat. We're not going to believe it. We're going to go away. The patient's going to desat again. It's going to be 3 or 4 times before we think, oh, this patient really is desaturating. So the controller managed the PE. Nobody even knew about it, but this was the only patient in 95 where the controller walked itself backwards. So what's really interesting to us now is we've written software that tells the controller, if you ever do that, alert the provider and flash a signal saying, hey, think about other reasons. Something's going on with the patient that is very unusual. So you now have a new order of vital signs. You can watch the watcher. So after 95 patients, we were able to demonstrate that you were safer. The patients had fewer hypoxic events, and oh, by the way, we saved about 38% or 34% of the total oxygen volume. And what's critical about this is the average patient was on 1.91 liters of oxygen by the time the controller got done with them. That means that's an oxygen concentrator. That means I don't need tanked oxygen. We have oxygen concentrators commercially available, militarily available, generate 3 liters a minute, no big deals. Now I can go, if I can just power my concentrator with a solar cell, I can ventilate a patient for the duration using this kind of system. So, clear please. So, what's the next step? Kenji, I promise you I'm going to see Kenji Inaba a little later this evening. We've been back and forth with the FDA now for almost 3 years. The FDA doesn't know what to do with us as we go forward for licensure because this will be the first time the FDA has ever allowed a piece of equipment to act and interact with a patient without oversight by a physician or a medical provider. So we've been in a long trial with them. We just met with them again last month. We put in what we hope will be our final piece of paperwork, and then we're going to go to LA County, UT Houston, and Cincinnati. We have to enroll about 200 patients on the software that's now resident in this ventilator. This is our next generation of ventilator. The software is already in there. We're not allowed to use it yet until we provide that data to the FDA. I hope if I have the privilege to come back next year, I'll be able to tell you that we've got the trial done. Okay, let's talk about autonomous care controllers because they work pretty well. Here's an example of how you can autonomously resuscitate a patient from hemorrhagic shock. This is data out of Galveston, which uses a sheep hemorrhagic shock model. And the moral of this story is that whether it's a human being or whether it's the algorithm, the sheep is resuscitated from shock just as rapidly as any other system. But if you turn it over to a controller that's constantly looking and adjusting, the controller can do it with about 1/5 as much fluid as the human being. Controllers also work, so this is one that really is kind of near and dear to me. Can you imagine, so here's a couple of examples of us moving. There's a Marine going up into the M-bus or a Marine loaded on the floor of a C-17 that's pretty noisy and bumpy. Can you imagine how much propofol it takes to keep a 19-year-old Marine with injuries sedated? And so, man, we use a lot, and when we see that Marine bucking, we just say, club them, give them another 10 per kilo of propofol because we have no exact way of titrating sedation. And true story, sometimes we'd get these kids up to Germany, it would take a half a day or sometimes 24 hours to get the propofol out of their system because God knows we don't want them waking up in the middle of a combat takeoff. Well, there's a better solution to that. This is really interesting. In Europe, they laugh at us because if you're in Europe and you're on propofol, you're on an autonomous controller. This controller simply does the calculation. It does the math. Propofol distributes very predictably based upon pharmacology and weight in kilograms. So all this machine does is says, what serum level of propofol do you want? You input that. And pharmacologically, it gives a bolus, and then it comes back down to steady state, and it does the math, the pharmacology of the distribution, the volume of distribution of propofol. And when it knows that it's at that end state, it just flashes a green light saying, okay, you're at 0.4 micrograms per deciliter. Now, tell me if that's good for your patient or bad, and you can adjust up or down. Well, your patient's still agitated. Okay, instead of 0.4, let's go to 0.6. You go 0.6. Boluses again, steady state, green light says check your patient, do you like 0.6? You say, yeah, that's where I want to be. Oh, by the way, if you look at this screen right down there, in the bottom of the screen, it's really cool because it knows the pharmacology. That 35 minutes is, if you turn that infusion off, your patient will be awake in 35 minutes. It does the math. It's there, it's available. We just don't have it here in the United States yet. Our friends down at the Army Institute of Surgical Research, the Burn Center, which is the legendary home of burn care in the United States, they've done closed loop. John Holcomb, Jose Salinas, Vic Convertino, and some of the, George Kramer, you can see they've been able to demonstrate using a decision assist system where you input urinary output and it'll tell you how much IV fluids. You can see here again that they can do that with less fluid. And actually, they've published a paper since then that they can actually change the mortality of seriously critically injured burn patients greater than 60% by using a decision assist system, and this is exactly what it looks like. We actually had some of these in theater while we were working in the 2008, 2010. Again, the FDA's having a problem with this right now. They're not quite sure how to bring this. This is not yet available on the market, but it is a tool that's been demonstrated to work effectively. Intracranial pressure monitoring. This was one of our projects that we took on a few years ago. Again, imagine it's one thing to have a patient who you have to do ICP monitoring on in your ICU where you have a bed, a KCI bed or whatever bed where you can bring them up, or realize that when we go on board, these kids are on a NATO stretcher and usually they're flat. We have to bring along a special little piece of equipment just to elevate them in the stanchions. The stanchions aren't like an elevatable bed. And then the next question is, do you load the head toward the front of the aircraft or toward the back of the aircraft? Because that aircraft's going to accelerate. That C-17 is going to take off and pull about 1.8 Gs trying to take off out of town. And then when it lands, it hits the brakes and it generates about 2.1 Gs when it decelerates. So what do you want to do? You want to pull ICP out of their head or push it in on landing, or how do you do it? So nobody knew. And so we took a look at it. No, by the way, that's about as sexy as a C-17 gets. The pilots think that's a really cool picture, but if you look, he's landing cockeyed there. That'll be what we call a two bounce. So we used to have the pilots sign us off for 2 landings whenever they landed like that. So it's not quite as good as he thought he was. But up here, this is an accelerometer tracing here, and so I could tell when the plane was taken off. And so here's the takeoff, the accelerometer takeoff, the plane's taking off. And then you can see that what happens during this period of time is that the patient has a real big ICP spike, all right? So what have we done as a result of that? We recorded about 30 patients like this, and sure enough, every time, regardless of whether they're head or feet first, it isn't head or feet first, it's landing and taking off, probably because they're very noisy, they're bouncing, and their sedation isn't probably as deep as they might be. So what do we do now? We open up the ICP monitors, and we're standing constantly monitoring during takeoff and landing. We have to, by concept or by protocol, we're standing watching ICP constantly now during takeoff and landings. But if you can use a controller in that kind of fashion, in that kind of constancy, now think about this. How about putting 2 controllers together? How about a controller that looks at ICP and uses George Kramer's fluid controller, and now instead of infusing saline, you can give hypertonic saline. If that ICP is going up and the MAP is low, why not give them hypertonic saline? Our controller can manage that. And instead of doing it every 30 minutes, or how often do you check ICP, and how often do you change fluids in an ICU? If you're really good, every 60 minutes. This sucker can do it every 6 seconds. And it can interact then with your autonomous ventilator controller, because if the ventilator thinks it needs to take PEEP up, it has to warn the fluid controller that I'm going up on PEEP. You may see a blood pressure drop. You may need to give more fluids. Nobody's done that yet. This is where it's going to get really interesting. We're had the good fortune. We're funded now by the Air Force over an 8-year project in a large porcine model to do exactly this. We're going to start working with multiple controllers. Our first attempt's going to be to have a fluid controller and a ventilatory autonomous controller talking back and forth to each other to see where the hiccups are going to be. The next thing that's become really apparent is what we don't know can hurt them a lot. So I'm absolutely convinced that the next thing we need to do is own data, and own data a whole lot better than we do. So here's an example of something we thought. We created a protocol because I had a young captain who wanted to do some research. So I tried to think of the simplest, safest, dumbest, easiest protocol, which took us 4.5 years to get the Air Force to approve. But what we wanted to do is look at what happens if you just watch somebody, one of these kids in this aircraft, one of the less critically ill kids, one of the kids who's not intubated. What do they look like with respect to oxygen saturation on the 8-hour flight to Germany? So we finally got that protocol approved. This is our hospital in Afghanistan. That's the Craig Theater Hospital. That's a recording oximeter that simply downloads and data logs everything, and this is Germany 9 hours away. So we got 35 kids, or 61 kids to volunteer simply to wear an oximeter. These were kids who were being taken out of theater for closed head injuries, for tibial fractures, status post appendectomies, whatever, but they were all kind of the walking wounded. And what was really interesting and scary is that of those 61 healthy young American soldiers, only 6 of them made it to Germany without being hypoxic below 90%. Well, okay, so they're up at 8,000 feet and maybe transient hypoxemia, but look at this group. This group, of the total of 61, 34 of the 61 were below 85%. And of that group, this 14 were down below 85% for more than 10 minutes. Asymptomatic, nobody's catching on to this. How did we, we're supposed to be monitoring these patients. The nurses are monitoring these patients, but unless you look at every last second of data, you don't catch these kind of things. So we need to own data a lot better than we do. Clear, please? So yeah, what vital signs? So it's interesting. Why do we take blood pressure? We take blood pressure because we can. Blood pressure was actually first really utilized in the First World War by Cannon and Cushing. It's actually never really been hard validated in the trauma patient population. I compare taking intermittent blood pressures kind of like to what it was like back in World War II when they had spotters over in England with binoculars trying to see an airplane. They'd see it there, and then they'd look again and the plane would be there, and they're trying to predict where the plane's going to go. Well, that doesn't work very well. That's like taking a blood pressure every 10 minutes. Where's the trend on that blood pressure? What's the patient doing? Well, if you think about how we fly an aircraft now, we do it with radar and we do it with continuously updated data, and that data then can analyze and predict where the plane's going to be in time and space, not just now, but 10 minutes from now. I think we need to do the same thing with our own monitoring systems, and this will be the final piece of what I want to show you a little bit about. I think monitors, for the last 50 years, monitors have simply monitored. I think monitors now need to do much more. They need to be used like you're using your laptops. They need to be integrators. They need to be analyzers, and it's possible. This is a very interesting monitor out of England called the Tempest monitor, which is essentially a very robust computing platform that also monitors vital signs. So the Tempest, among other things, will do data keeping for you. This is a touch and play. 5 minutes, great, thanks. Touch and play so you can record your data. It looks like that, but now here's where it really gets cool. The people out of the ISR have validated this. This is called the Cardiorespiratory Reserve Index. This can, with 95% predictive power, tell you when your patient's going to have decompensation from hemorrhagic shock. So essentially, and it's in the validation phases right now, but essentially utilizing continuous analysis of pulse volume variability of the finger plethysmography signal. God, I said all that. You can essentially now, for the medic, for the EMT, you can give them a speedometer. And literally you can do that. The patients in the green zone, they're fine. The patients in the yellow zone, they're starting to decompensate. Patients in the red zone, you have about 5 minutes to react and resuscitate, or the patient's going to go into cardiovascular collapse. This is what it looks like. We're actually going to participate with this group. We're going to put some of them out on our fire department rigs in the city of Cincinnati. This Tempest has really robust reporting capability. What's really cool about it, though, is about 4 years ago, working with them, we said, look, every time something new comes along, we have to wait to buy a whole new piece of equipment. Why don't you give us USB plug and play? And that's exactly what they did. So they went back, and instead of having to integrate onto the circuit board, what they did is they brought USB plug and play. So right now, the Tempest Pro, which is what we're looking at to make our next generation of monitor, on the side there, there's USB plug and play with ultrasound. So now when I'm flying and I need to do an arterial line or an IJ line on board an aircraft while we're flying, I don't have to carry an ultrasound machine. I don't have to carry new batteries. I don't have to carry new transformers. I just carry an ultrasound probe that has a USB port on it, and I plug it right into the Tempest Pro, and I can see the screen real time. And then check this. Video laryngoscopy, plug and play, and oh, by the way, 16 video frames a second. You can transmit anywhere you want, SATCOM, encrypted across the military channel. And somebody like in Kuwait can be talking to the medic in their ear with a Bluetooth dongle, and they'll be seeing and talking to each other. We've got 3 of these out in City of Cincinnati now, and we've had some fun working with the medics. You can actually sit and watch the medics do video laryngoscopy and cue and coach them. And so I think this is really cool. All USB plug and play, and oh, by the way, it records every last piece of data, and here's the next place I think we can go. Because what we want it to do is, when you turn it on, we want it to ask you, who are you? And based upon what you tell them, the monitor will configure itself and give you different algorithms. If you're a physician or a CCAT doc, you'll have a different set of algorithms than if you're an EMT or a medic in the back of the helicopter. It's the same thing you ask your computers to do. So, a lot left to do, a lot of things and challenges in front of us. We have a very sacred mission that a number of members in here have also shared with me. Yesterday was Veterans Day. It was a great day for all of us. Peter, you've had great service, and a number of other people here I'm sorry, I'm failing to recognize, but there's a lot still left to be done, and I look forward to talking to all of you. Pete, thanks for having me out.